Morning, everyone. I have the great honor of introducing the esteemed Danilo. I've known him for many years, but it's always an honor, and I always learn something every time I hear a session of his. So let me go ahead and introduce Danilo, or Danny. And he's been a practitioner since 1995.
75.
75, yes. I was going to say 50 some years. So he is experienced in the clinical, technical, research, administrative. He's done it all. He's on the executive committee for this meeting, and a very important part of the meeting. He has been a contributor to many journals. I often will pick up a journal and there's his name, and he always has some excellent information. He has, and I always think of him too as part of the Amy, as part of Amy, because he's really written the APIC elimination guide, the guide to elimination of infection in hemodialysis. He's been on the Amy committee for many, many years. He's also a member of the ASN, Centers for Disease Control and Prevention, and he's on the editorial board of Nephrology News and Issues. And his picture was on last month's issue, so I have that here. So come on down.
Okay, great. All right. My contact information is there. I am an employee of Providence St. Joseph Hospital in Orange, California. Like Sheila said, I've been there for 50 years. One place, didn't move, didn't get acquired, always been St. Joseph Dialysis. And it's hospital-based, Christian-based. So our focus in the hospital is one thing: patient safety, patient efficiency, and not the bottom line, because the bottom line is taking care of all the other services in our hospital. Our job is just to maintain that we're budget neutral. And boy, they tried budget neutral real hard. I do have one disclosure. I am on the technical advisory board for Dialysis. And today's presentation, I was supposed to have a partner here for this 90-minute presentation. As you can see, I'm the only one up here. So there's going to be some fillers in my presentation. And it's participation, audience participation. And that presentation is in the words of these kind of puzzles. This. Does anyone know what that says? It's phrase or words? Anyone? This is a test one. You don't get a Starbucks card for this. In the embedded ones, if you get it right, you get a $10 Starbucks card. So this one is a sample of that puzzle. Any guesses? It's mixed bag. Okay, got it? Mixed bag. Okay, today's objectives is to discuss technological challenges for the dialysis caregiver, recognize the rationale behind technological challenges, discuss the hidden perils of the dialysis treatment. Question: if there is no alarm, is there no problem? No. But then why do we act like there is no problem if we don't hear any alarms? How many times have you seen a whole treatment with the blood pressure set for every 30 minutes or every 50 minutes that the caregiver does not go back to that person until they come off? That happens too often. Just because there is no alarm doesn't mean there is no problem. Case in point, I don't know if you ever heard or read the article some time back where a patient on dialysis treatment actually died, and they didn't know he died until they were taking him off. That's unforgivable. Technology is fantastic. It gives us so much tools to make our job easier and safer, but it's not foolproof. It doesn't cover everything. So be aware, just because there is no alarm doesn't mean there is no problem. Okay. So pre-dialysis issues. Incidence of clustered bacteremia in one facility. Enterococcus caseoflavus and aerobic gram-negative bacillus. This was not protected by technology. It actually occurred. And these patients, blood cultures came back positive for these incidents. The only way that you can get that type of organism into the bloodstream is to what? To inoculate the patient with that organism. The dialyzer is a fantastic guard from dialysate to the blood side in letting those kind of agents or those kind of contaminants reach the blood side. Any guesses of what caused this? It's during priming.
Something was a bicarbonate of the wall box.
No, it wasn't, but there's something else with that. No, it happened actually this. You're all familiar with the priming buckets. The priming buckets has clips intended for a purpose. It's to make sure that when you clip the venous line into that effluent bucket, that it's clipped as close as possible to the top. The reason is that as you're priming, the saline rises. If it rose to this point, guess what happens to the venous tip? It gets saturated with whatever organism or contaminant is in that bucket. You hook up that patient to that venous line, what happens? Direct inoculation of that organism. No alarm, but it happens. Okay, this one. Multi-center outbreak of gram-negative bloodstream infection in hemodialysis patients. And the cause is exactly what you said. This came from the CDC. This is a multi-center outbreak of gram. My slide here is so small, I forgot to put my glasses on. So, I'm 74 years old, so my vision was one of the first things to go. Oh, it's in my bag, thank you. I apologize.
Oh, she's big.
Thank you. One of the things that you should always do in dialysis before you patient on, get prepared with everything you need. And obviously, I'm not. Okay. That's better. Multi-center outbreak of gram-negative bloodstream infections in hemodialysis patients, and the cause of this, as investigated by the CDC, is the wall boxes. What was happening is this part of the dialysis treatment, which is part of the station that's supposed to be part of your surface disinfection, was being completely ignored. So it wasn't being wiped down between each patient treatment. And what was happening is that the connectors, excuse me, the acid connectors and the bicarb connectors were being cross-contaminated, which then brought it to the proximity of the patient care itself and cross-transferred to the patient. So the requirement here is now that prior to, excuse me, at the end of each treatment, that wall box is supposed to be part of your station disinfection. If you can't do it every treatment, CDC says at least do it at the end of each day. Yep. Sure. Manufacturers IFU to prime at 150 ml. And then most companies have this similar instructions. Not one company that manufactures dialysis says to crank your blood flow to 400 so you can prime faster. That is not the case. But do you see that in reality? Our staff are very good at trying to invent ways of actually enhancing and increasing their ability to put the patients on as fast as they can. And one of them is, during priming, you crank up that blood flow so that you can get that initial volume filled of that dialyzer. And most of the manufacturers, and forgive me for doing one manufacturer's items, because that's what we use in my facility, but all of the dialyzers manufacturers are similar to what this one company does, including the machines. They have their different principles, but all of them use the same methodology and same safety features, some more enhanced than others. But anyway, these caps are intended for a purpose. How many times have you seen staff actually throw those away before they prime? And this one here, this is, if you've not seen what a fiber looks like, it actually looks like that. There's over 10,000 of those fibers in that dialyzer. And it's very, very permeable to fluid water, KUF of 45. In the layman's term, if you would to do a calculations, that would mean that that 45 KUF is capable, if uncontrolled, to ultrafilter 45 pounds of water an hour. That's a gross approximation, but that's capable of doing that. And then as you see here, it says the instruction, the 150 ml. And then the KUF is there. Dialyzers have an intrinsic resistance to flow at the end of the venous header. They have a resistance to flow about 200 millimeters of mercury just to flow without anything. So being so permeable to water, what happens when you introduce that is that if that cap is not in place, what is water or normal saline tend to do? It takes its least path of resistance. So, resulting in inadequate plant fibers, resulting in air liberation and clotting during dialysis. And two causes are orientation of dialyzer arterial end up during priming and priming too fast. So, how many of your practitioners, or how many times have you experienced someone saying, I've got air in my line, I don't know where it's coming from? It could be coming from the fibers. And the reason for that is, if you look at this, remember I said that the KUF is very high, that it's so permeable to normal saline crossing the membrane? Oops, I better stay here. I see far, but I can't see near, so I'll be taking it off and on frequently. So saline comes in. If that cap was not there to actually retain the pressure, the saline will take its least path of resistance. And it could be down, and you can hear air locked in here and comes out of that fiber, and then re-emerges past that airlock and out your saline. If you have multiple fibers with that scenario, guess what happens when the blood comes in? Blood is so viscous that blood will force that airlock and liberate it into the venous segment. And obviously, with the 200 resistance of the venous end, the faster the blood flow, the greater the ultrafiltration. And that's why they maintain that your blood flow has to be at that minimal speed so that you don't have air in your system when the blood comes in. Okay, you ready for the first $10 contest? So, first one to shout out the answer gets the $10. What foot in the grave? You got this. You played this before. There you go. Why do we do UF pressure holding test prior to each treatment on high flux dialyzers? Yeah. And this is from an IFU. Due to the high water flux capability of high permeability membranes with an ultrafiltration coefficient of greater than 8, it's necessary to use such dialyzers only in conjunction with dialysis machines that are equipped with precise ultrafiltration control, such as I bought that because I'm not supposed to be biased manufacturer. In any case, the safety instructions for the hemodialysis must be followed. This is a typical hydraulic package diagram of two of the more commonly used machines on the market. As you can see by the diagrams, I've had it blocked off in both sections. Ultrafiltration system is a closed system, meaning that there's no open avenue to atmosphere for anything to escape accidentally. So how it works is that the fluid comes in a balancing chamber system, regardless of which system, and it's an equal exchange. 30 cc's goes in, and 30 cc's, the fluid goes in at a volume, and what goes out is the same volume. And that's how it's actually actuated as to when the sequence occurs. Okay. So, take for example, that closed loop as a vial. If you had a vial and you took out 30 cc's out of that vial, what can you put into that vial? 30 cc's. Yeah. But what if you had an open avenue and you introduced 30 cc's into there? How much can you keep putting into there? Indefinite, because there's an avenue for it not to maintain that pressure neutral. And so what happens in your pressure holding test is that it's testing you whether that configuration or whether that closed system is still intact. How many times have you seen a machine with a leak under the machine and the staff keeps using it? It happens. They tell you after the treatment, but know that that machine leaking, you don't know where that fluid is coming from. It could be coming from the patient. Remember that your ultrafiltration is created by your transmembrane pressure, which is a push and a pull. Can fluid be pushed out by venous resistance? Yes, it can. And if you have a venous resistance of 200, multiply that by 50, what do you get? 10,000? That's a high ultrafiltration rate that you're not registering or monitoring. And we know this for a fact because we've seen incidents where the blood going into the dialyzer is different consistency and color than the blood coming out of the dialyzer. The blood coming out of the dialyzer is so hemoconcentrated that it looked almost black. And that was because there was a leak in the ultrafiltration system that was actually failed during test, but the staff didn't want to change the machine. No alarms. But the patient hyper ultrafiltered because they chose to ignore the signs the signs of the machine needing to be attended. And that's it. So this is actually that calculation. If you have a KU of 50 with a TMP tolerance of 600, if you had one of those scenarios, if you had 50 times 600, which is again the capacity of the dialyzer, you've got 30,000 mLs. 30,000 liters times 2.2 is 66 pounds an hour. You're dialyzing that patient on a system that has a non-contained ultrafiltration system at 66 pounds an hour. Technology is there, but technology is not foolproof. Yeah. So low TMP, high TMP, we all know the difference. It's a push-pull scenario. And for low TMP, kink tubing post-dialyzer is actually the cause of that, because when you have a kink post-dialyzer tubing, what kind of resistance is now being subjected on that venous end of the dialyzer? It can't go through, so the fluid has to go someplace and out. And so your TMP actually falls, becomes positive. And then also clotting in the venous header causes the same problem. And a saturated venous transducer protector actually can cause that kind of TMP because the machine can no longer electronically monitor that there's a pressure depth variations in that dialyzer. So if you have a wet transducer, make sure that you do dry it. It's almost like if the wet transducer becomes wet, it's almost like clamping it. And that's the effect that you have. So if you have a venous dislodgement and you have a wet transducer, is that venous reading going to change? It won't. Yeah. And high TMP obviously is kink tubing before the dialyzer because now the machine is pulling and there's no more fluid coming in. So what happens to the negative pressure? It increases. And then clotting in the arterial header has the same thing. Here's one. No alarms. Analysis performed using hemodialysis patient safety data confirms that alkalosis is a significant factor associated with cardiopulmonary arrest in the dialysis unit, independent of an additive to the risk of CP arrest associated with pre-dialysis hypokalemia. This actually made if you stay up as late as I do, all the lawyer lawsuits a while back that was targeted towards one company. And the reason for that was that not only this technology, you have to be very aware of what technology affords, but you also have to know how to interpret the technology that you're using. Is anyone familiar with this or not familiar with this? You are familiar. Some are. What occurred here is that on a normal dialysate concentration and sodium buffer, you have acetate contribution, whether you're using one form or the type that you mix in center. And then you have your bicarb setting. On this one particular one, I believe it should be the normal dialysate, not the one pre-mixed. No, I take that back. Okay, when you mix your own concentration, the contribution of your acetate component is 8 milliequivalent. On a normal jug, it's 4 milliequivalent. And what was occurring in this is that this is actually the value that the sodium bicarbonate load is contributing to patient experience. The problem is that acetate is converted to bicarb. So if you were to set your machine, which is a value that happens before that systemic contribution, and you think that that's what the patient experiences, it really isn't, because you have to add the 8. So the total patient buffer experience of the patient is 41. The problem here in this scenario is the physician and the caregivers did not understand or was not on the same page when orders were being given. So the question is, did the doctor want the machine set at 33? Or did he want patient experience at 33? Most of us did what? He ordered 33, we set it at 33, not considering the bicarb load from the acetate. And so patients actually arrested because of that, and that's why the lawsuit. One entity was blaming one, and the other entity was blaming that. No, you doctors ordered that. No, you manufactured that. I don't know who won.
Fresenius ended up paying.
Did they?
$200 million.
$200 million? For that one company, I'm not supposed to say those.
I know, but I
Okay. So apparently the company ended up paying $200 million. Okay, you ready for another $10 gift card? Huh?
Space Invaders.
There you go, Space Invaders. That lady in the back. Have you been in some of my other lectures?
Nope.
Okay. Because I haven't used, well, it can't be, I haven't used these word slides, oh my gosh, probably in close to 15 years. Yes, I have been lecturing for a long time. I apologize. I did my first lecture for AME meeting in 1997. And back then, oh my gosh, that was the first time I've ever been on the speaking podium. And prior to that, I was so stage fright, it was ridiculous. And I did the unforgivable thing that a speaker should do. I used notes. Guess what I did with those notes? I dropped them. So ever since then, actually, I was going to give up my lecture, my being lecturer, then except that a very well-noted physician came up to me. I don't know if any of you know Dr. Nathan Levine. Right? Dr. Nathan Levine came up to me and goes, Danny, it doesn't matter. You're here. You're what we need to hear, so don't stop doing it because you are in the front line of the caregivers. And so he gave me some word of encouragement, and so it's his fault that I'm standing in front of you. Interdialysis issues. Now, I put this first slide because of a conversation I had with the patients. Do you take into consideration the clothing that people wear for dialysis? As you can see, too much weight off doing the incorrect pre-weight. Sweatshirt is 0.8 pounds. Jacket, 1.5 pounds. Tennis shoes, 2.2 pounds. Short sleeve, 0.4 pounds. I did this because my patient had a Friday outfit. On the Friday outfit, if he wore those heavy materials, guess what his weight looked like? High. So what's your job? To try to take as much off as you can to achieve the target weight? And you do that. So on Monday, they come in, guess what? They're wearing their Monday outfit, which is the lighter outfit. And goes, oh. Patients don't like to be chastised for gaining too much weight, right? So some of them are very smart. Well, all of them are smart. But again, some of them have schemes just the way we do as workers and trying to figure out how, I don't want to say cheat the system, but make the system work for us. So be aware that clothing does make a difference in the things that we're doing. Well, okay. This obviously is a kink tubing, and that can cause hemolysis. Is it being monitored by any of the systems in our machines? No, it's not, because it's post-dialyzer. I mean, it's pre-dialyzer. That's the arterial. So what would happen is your TMP is going to possibly negative pressure rise, right? And so that would be the indication. But it may not, because it takes a lot of restriction to actually change the TMP. That can cause hemolysis, but it may not cause TMP changes. And that's hemodialysis due to kink tubing. Systems clot due to alarms not observed. Patient expired on dialysis was not observed for almost an hour. Again, these are events that occurred without an alarm. And this is more from my other hat. I'm also a biomedical engineer. And one of the things that happens with some of our components is that, again, there are methods to actually unstring your blood pump segment. There's a little button that lets you, and all machines are the same way. But what's the faster way of actually, you start a lawnmower. You put your foot on the machine, and boom. And we know they put their foot in the machine because why? We've seen footprints on the machine. And what happens to that is that these roller guides bend. We have seen incidents where the roller guide have literally ripped the blood pump segment and leaked into the machine. So please, when you get back, tell your staff there is a method of doing the right things. Decrease in KT over V. Incorrect heparin administration could be a cause. Because again, if you have incorrect heparin administration, what happens to the membranes? You lose surface area because of clotting, which results in decrease of KT over V. And then concurrent QV and QD. In today's technology, it's very difficult to do that. But back in the Stone Age where we were cranking our own machines, when I started dialysis, there were no color coding. And actually, this occurred quite frequently where we had both dialysate flow and blood flow going the same way. Now, there is actually a use of concurrent QB and QD. One of my physicians asked, we're clearing the patient, how do we slow down the clearance? If you do both flows, blood flow and dialysis flow in the same direction, you actually decrease clearance by almost 37%. So if clearance, pulling off too much shifting is a problem, my physicians have ordered this. And time on, time off dialysis. Again, this is a huge thing that is not a debate, but is practice. When does your staff start time? When the blood hits the dialyzer? Good. Not when they turn on the blood pump. Again, the practices has to be observed to make sure that your staff is doing the appropriate thing. Because when is time supposed to start? Not when it reaches the blood, the dialyzer reaches the blood. It's when you achieve prescribed blood flow. That's the time start for your calculation. And from that moment where you put your patient on to when you achieve blood flow prescribed, could be 5 minutes, depending on what's happening with that patient. Is 5 minutes critical in your calculations for KT over V? Yeah, it can be. Yeah. If you're looking for 1.2, which CMS is required, and you're at 1.18, that 5 minutes could actually give you that 0.2 difference. Okay. Wrong ID setting. Some machines have the 6.3, 8.8 setting. So if you do have the wrong setting, it'll give you the readout, but the rotation of the blood pump will be different. Note that in a layman's approximation, each rotation of the blood pump roller is how much? You can literally guess and approximate your blood flow by counting the revolution of the blood pump. Each revolution of the blood pump is 10 cc, approximately 10 cc's. So if you're 200, 20 times. So if you're ever in question that your blood flow is not where it's supposed to be, do an approximation by counting the revolution. 10 cc's per revolution. Yeah. So, okay, this one. Blood flow delivered is less than displayed set blood flow. Arterial resistance does make a huge difference in the actual blood experience or blood flow experienced by the patient. If you look at this is a blood flow of 400. You have your arterial pressure at minus 90, minus 175, 250. The effective blood flow is no change for minus 90. But look what happens when you increase the arterial resistance. Your effective blood flow is now at 373 instead of 400, and your effective blood flow at minus 250 is 358, a decrease of 10.5%. Okay. So there is a direct relationship of your arterial pressure to your blood flow. So if you're in your QAPI questioning why is 400 not giving me the KT over V, that could be a possibility. Yeah. Effective clearance is reduced by 15 to 25%. Oh, excuse me. My apologies, that's in the wrong place. That was before. Blood loss. We all know what the cause of blood loss is in dialysis. Unfortunately, is it always covered by technology in preventing the patient's blood loss? Access covered during treatment is obviously one of the biggest causes. And the biggest resistance to that is the patient themselves. They get cold. And we like to keep the environment cold because it's more supportive of supposedly blood pressure. The colder air. Yeah. I don't know if there's a science to that, Dr. Laxon. Is that true?
The Mind Camp study
It's not?
did not fully put good outcomes, but it is true. There is some impact.
All right. Thank you for supporting.
It's really because we're hot.
Huh?
It's really because we're hot.
Oh, okay. The staff, right? Okay. Resetting alarms without investigating cause. How many times have you seen staff immediately silence or reset without investigating? Again, like I said, our staff gets accustomed to almost being comfortable in their surroundings because they do somewhat have such a confidence that the machine is helping them take care of the patient. That exists with today's technology. The technology of today does make our staff somewhat more comfortable with, I hate to say it, ignoring the patient.
There are some patients who also have learned to press
Yes,
alarms.
and that's, yeah. Yeah, and that's why we lock our wheels so that they can't move their machine. Because we've had that in the earlier days, and so we make sure that all our machines are locked. And actually, by CMS guidelines for emergency preparedness, you're supposed to have those machines locked for emergency preparedness. Meaning that when in California, we have earthquakes. So what happens during an earthquake? The machines will move. So it's part of our requirement. And then this one, distraction while phlebotomizing. I was actually asked to be an expert witness at a trial where one of the patients actually died because of this incident. What happened here was it was in an acute setting, not in an outpatient setting. In an outpatient setting, you have the confidence that your caregivers alongside of you is also helping you watch things, I hope. But in an acute setting where you're independent and solo, this particular case, the patient was being initiated on dialysis. The caregiver's phone went off, got a call, answered it, not realizing that caregiver did not turn the blood pump off or connect the patient on. Answered the phone, the doctor was giving orders to that caregiver. And how many doctors give orders quickly, Dr. Laxon? So unfortunately, in this case, by the time that person finished the phone call, got back to the patient, the blanket was so saturated and the bottom of the machine was so saturated because he had splashed that the patient did not recover. So even a simple task like putting patients on, it's almost like you have to follow how you administer medication. What is the rule for actually doing medication for the nurses? You have to be isolated, you have to be undisturbed. And it should be the same way with initiating dialysis. We have so many distractions. We stack tasks in dialysis, meaning that we as caregivers are doing multiple things at the same time. So please, when initiating dialysis or discontinuing dialysis, don't do task stacking. It is dangerous. Okay? Yeah, that's the new term that came up with the human factors engineering study. They came to the conclusion that we have so many disruptions for infection control because we're task stacking. A machine that's so proximal within reach goes into alarm. So we leave this patient and go to there and then do things here without doing what? Hand hygiene and proceed with what we're doing. That was one of the number one culprit of cross-contamination is task stacking. Saturated venous transducer protector, as I said, it can act like you clamp that monitor. If your needle dislodges, you won't get an alarm because it's a wet saturation. There's no transfer, there's no change in your pressure readings. And obviously, we've seen this before where you have a problem with the cannulation and you put a third needle on, but if you ignore that needle and it comes unclamped, what happens? You're still going to get blood flow out of that third needle. And chances are it's going to be under the blanket. Know that in your venous dislodgement, this was actually a measurement study that was done. If you look at the top line, that's your 260 above the real value. This is the real value. This is the bottom limit of that value. This was predicated on, I believe, hematocrit of about 35 hematocrit. Yep. And what happened during the disconnection is because of the viscosity of that blood coming out of the venous region, your disconnection pressure fell to only that. It never violates that limit. So make sure that when you do set your venous limits, it's to its widest spread. Why do we set it at the widest spread? It's less alarms. We don't want to deal with the alarms, but it's not the safest methodology. Make sure you restrict it as much as you can so that this does not happen. Okay, who wants a $10 gift card? Who said that? There you go. It's income tax. Got it? I know $10 isn't much, but I didn't have the budget. If I had advertised a $100 Starbucks gift card, this room would be completely full. Okay, verifying blood pressure. How many times have you questioned your automatic blood pressure? Many times. What do? You go get a manual, right? And then put the manual on. Know that actually there's an instruction for use in one of the older manuals to verify blood pressure. If you have a question, you put on the cuff, initiate the blood pressure, and take a stethoscope. Use the stethoscope, and while the machine is decaying in its pressure, watch the pressure on the machine because that is accurate. That pressure monitor, that transducer is very, very accurate. And it's going to give you the correct pressure reading. It might not give you the correct blood pressure, but that reading is correct. So you use that as your gauge while you're listening. And then what you hear in relation to that pressure is your blood pressure accurately. Unless you're deaf. Right? So for an inaccurate auto beeping, don't keep looking for or asking, do you know where the manual blood pressure cuff is? They do that. You have one on your machine. Use it. All you need is a stethoscope, which we give each of our caregivers that quickly disappeared the week after.
You should have told me that 20 years ago.
Huh? Okay. Why is a high arterial negative pressure not good for the patient? I actually covered that already. I apologize. Conductivity issues. How many of you had run into conductivity issues during treatment? Everyone, right? Okay, this is the concentrate formulation. There's actually 4 different distinctive type of formulation on the market. The 35X, 36.83X, 45X, 36.1X. Okay, audience question. What's the most commonly used formulation now on the market? 45X, which is great because again, 35X was the secondary one that was used quite extensively. Yeah. So what that means is that there's a proportion ratio. If you look at 35X, we've got a ratio of 1 part acid, 1.225 parts of bicarbonate, 32.2775 parts of water. That is the recipe for the 35X. 45X, which we now commonly use, is 1 to 1.72 to 42.28. What that means is in order for us to achieve the same ionic concentration when something is being diluted more, what has to happen to that initial concentrate? S has to be higher because you're diluting it more and you want to achieve the same ionic concentration that you do with something that is being less diluted. Correct? We get the equal relationship. So, how many of you are familiar with conductivity prior to each treatment? Yeah, it is. The reason for that is that when the 3-stream system came about, we were still using acetate as a secondary, an alternative concentrate, where it was one connection, one job, or one concentrate, acetate. The facility at this place actually just converted over to three-stream system. 3-stream is you got water, bicarbonate, and bicarbonate. They converted to the 3-stream, but guess what happened to the ordering pattern of the people that were ordering the supplies that didn't know about dialysis? They ordered the 45X acid. Their machine was still set up to be 35X. What happened when the 45X concentrate was plugged in to that 35X formulation, you had enough ionic concentration in the acid to achieve a working conductivity that didn't put the machine in alarm. The whole facility's population was actually treated for severe acidosis because they were dialyzing on acid only. And that's when the manufacturer said that you have to now do conductivity and pH. That's where that rule came from because of that one incident. And now you're obligated to do that because what does CMS say about conductivity? CMS says, follow manufacturer's instructions regarding conductivity and perform pH. Right? So regarding conductivity ratio, this is one example of one manufacturer's indication of flow. Every time that ball goes up and down, it's a movement of about 30 cc's of fluid. And same thing with the other company is that their balancing chamber is predicated in a small volume in that balancing chamber system of their machine. So the movement is a very slow volume. It doesn't look like a movement because it's seamless, because opening and closing of afferent and efferent valve is so timed that you don't notice that there's a slight cessation of flow. You can't notice that. So that's the movement. So you've got 2.2% of your concentrate or your dialysate is acid, which is 0.66 ml. And your bicarbonate is 3.8%, which is 1.14 ml. And your water, your RO water, is 94%, which is 28.2 ml percent. So actually, this happened. See, you don't notice that there's actually no flow. It's just a slight drop. Okay. So in that configuration, a slight, simple reduction of any of those components, change of component, will highly affect your conductivity because it's such a small volume. If it was a large volume, a slight change wouldn't matter. But being such a small volume for flow, it does change that. And a lot of things will change your concentration, and I'll show you some of that. But in the meantime, if you are spiking your concentrates, especially in an acute unit or especially in a facility where doctors think that there's a big difference between 1.25 potassium and 1.5 potassium, we have those. I worked one time in my facility when we had so many physicians with privileges come in. We had 25 different formulations. 25. So finally, we put a stop to it by getting all these literatures that says, no, it doesn't really matter. And some of them your articles, I don't know. But anyway, if you notice, the indication for what proportioning is for is actually on the containers. Oop. I did a bad job. I didn't blot those out. My apologies. But in your spike concentrate additive, the same symbol actually does exist. So make sure that it's not a square or a circle, but a diamond if you're using a diamond in your concentrate container. Also too, and I don't know why they do this. Well, I do know. Some of the companies, when they give you a jug, it's 3.43 liters. Some of the other companies would be 3.785 liters. If you note on this has the specific volume for each of what is for. So make sure you use the same volume as well as the same proportioning. Because that will change slightly. Potassium changes it. If you were to increase potassium by 2, you won't see it in your conductivity panel. It will not change. The greatest contribution to your conductivity is what? Sodium. Yeah. So the small changes in your potassium, calcium, Buffer, yes. If you were to increase your buffer solution, what happens to the conductivity? Does it increase or decrease? Conductivity decreases because it's a buffer. So if you increase bicarbonate, your conductivity will be lower, not higher. Ain't that pretty? That too should be part of the wipe down in your disinfection. Because even tiny specks of concentrate on your O-rings can literally change your conductivity. And air, even a tiniest amount of air into your concentrate line will change your conductivity. And that's the same thing with bicarbonate. And a lot of times what happens is these O-rings, because it's not being wiped down and crusted salt acts like a sandpaper, those get torn. And if they get torn or a little nick, guess what happens to the conductivity? It goes down. So if you're the type that facility that lets caregivers change the O-ring, know that there is a big difference in the O-rings of any manufacturers because connectors for the manufacturers are scored so that you can't connect bicarb to an acid. All of them, regardless of what company. Okay. So note that these are 2 different sizes. If you put one or the other into that connector, guess what you get? Conductivity issues. Okay. Okay, this is another $10 puzzle.
Count Dracula.
Yeah. Count Dracula. How much time do I have? Okay. This one is, this is necessary for the operator to follow the manufacturers regarding dialysate conductivity and to measure approximate pH with an independent method before starting the treatment on the next patient. Yeah. This is a very old picture, but this is where that requirement also came from. That little panel there, it's actually a plastic cover. And that plastic cover actually covered the acid adjustment wheel. It's a mechanical wheel. And anyone, caregivers, patient, can change that setting merely by just dialing up or dialing down. Conductivity here, there's a little tweaker here that actually if you took a little pot tweaker, you can change the reading up or down. When conductivity issues were being experienced, did they call the biomed? What they did was they took that cover off. If the conductivity was low, what did they do? They cranked it up to deliver more acid. Same thing with the bicarbonate. The bicarbonate had one in the back of the machine similar to that. Or the other method that they used was, okay, my conductivity is alarming. This is easy. I'll go ahead and change the reading. And that happened multiple times on different occasions. So what ended up was a concentrate that was said to be normal concentrate, but was no longer a normal concentrate, because when the issue that actually presented itself to give you that conductivity issue was corrected. Did they correct the settings in these machines? No, it did not. So it alarmed again, and so you changed it again. And that's when the requirement came that you must match your reading to a handheld to make sure that all those manipulations did not occur. And this has existed since the late 1970s. But in today's generation, regardless of being one manufacturer or another, all of them now, does not allow the caregiver to do any maintenance calibration adjustment. It's impossible. They don't even know how to do it. So the ability to change the reading and change the setting was eliminated in 2008. But here we are, 2025. What are you all still doing in most of your facilities? Conductivity prior to each treatment. When it's low. I have argued for years, even at the AME table, to say, get rid of that. I don't want to say things. Am I being recorded? So finally, the manufacturers have bent a little bit. So their IFU actually have changed, specifically with one of the manufacturers saying that if you use a certain option, you don't have to do conductivity, you don't have to do pH. So that is now in the manufacturer guide. And CMS is now accepting that. Is that, okay, we're following manufacturer's recommendation. Another company made it so that it says, instead of prior to each treatment, their IFU says, verify conductivity with an independent means routinely. So you know what routinely means in most places? When the biomed that does their calibration, that's routinely, so that the caregivers on the floor does not have to do it prior to each treatment. And all the manufacturers have followed suit. So hopefully you won't be cited for not doing conductivity prior to each treatment by the surveyors. Okay. Patients' electrolyte pH at critical levels.
And still, the setting on the conductivity alarm can still be manipulated.
Yes, but to a safe degree though.
1 milli, up to 1 millisiemens, so that it's supposed to be 0.5, 0.5
Yep.
up and below.
Yep.
But if you put all of that
Mm-hmm.
on the low end, for example, or the high end,
Yep.
And that can potentially,
It is. Like I said, technology is not foolproof. And also, too, if you look at the dynamics and the concentration of manufacturing, there's also a deviation of exactness. There's about a 5% deviation in its accuracy. And when the biomeds does there's also a degree of variations in that. So the total contribution of are we ideal is really, yeah, again, no company that I know of has made that spread smaller, unfortunately. Maybe with the new technology that they're concentrating on for hemodiafiltration across the world, because of its need for greater accuracy and greater quality, might decrease that spread. Yeah.
for example, sodium,
Mhm.
measured dialysis delivered sodium to prescribe sodium. So as you say, there's the manufacturer
Mhm.
for the concentrate.
Yep.
There's a plus minus allowance. And I think it's like 2.5. But then when you look at the machine, there's a plus minus allowance too.
Yep.
So when you start adding
It is.
all those plus minuses, we look at our dialysis,
Yep.
and it was plus minus 10
Yeah.
of what you think.
Yeah, I would suspect, in those institutions where you're worried about the bigger spread, there actually is speak to the biomed about restricting and putting it so that the default doesn't allow you to do all those. So there is a way to do that. Yeah.
And then the last piece we had was a pressure sensor.
Mm-hmm.
Because if the water pressure was too high going into the machine,
Yep.
that also affected.
Yes, it will. Actually, not just that. If you're central feeding your acid and your bicarbonate, and you do not have a pressure control for those two, that can give you more acid concentrate and more bicarbonate. But in today's technology, it will pick it up though. You will still get the alarm. So external contribution to concentrations like that may not be controlled by the caregiver is actually being monitored by the machine. Safely, yes. Accurately, efficiently, not really, but it is safe. All the manufacturers, because when they get their 510K, has to prove the safety and efficacy of what they design, and that's part of it. Yeah. Okay. Changing that. Actually, I already went through this in an earlier run with the change in pH and clinical levels with the change in concentrate. So we go to this one. Why is bleaching of machines necessary when heat disinfection is more convenient? And again, some of your machines do heat citric, but they still recommend that you do bleaching at least once a week. Okay. Bleaching is not disinfection as we use it. And that's why when I hate bringing up surveyors, because if it's being recorded and they listen to it. Anyway, so when surveyors come into my facility and say, show me your bleach log, I say, why? Because you're disinfecting. I said, no, we're not disinfecting. We use heat as a disinfection. And the reason why you check the log for your disinfection is to denote that you do not sample for cultures of bacteria immediately following disinfection. If you're heat disinfecting your machine every night, is there going to be a lag time between disinfection and sampling? No, there isn't. Your proof is you're heat disinfecting every night. Why does it need to be cultured? That we just included with our monthly. Anyway, so it's a cleaning process, and what it cleans is this. In every machine, there is a prism that actually denotes infrared light. When dialysate passes through that, an infrared is actually transmitted on one side, and on the other side is a receiver. That receiver has to receive the same intensity of light that is being transmitted through that prism. If it doesn't, something is blocking it. And what is usually that thing? Blood. So if that's cloudy because you haven't bleached and denatured it with some of the things that can actually make it cloudy, is it doing the same thing? Yeah. So if you're getting a lot of false blood leak alarm, somebody's not bleaching your machine. Know that blood sensitivity of this is it'll pick up 0.35 ml. That's how sensitive that detector is, 0.35 ml of blood going through that fluid. And then blood on just as a FYI, the level detector, it denotes 0.05 ml of air into that chamber. So will microbubbles go through that level detector? Yes, it is. Yes, it will. There is no such thing as an absolute air detector in our system. It's 0.05 ml is its sensitivity. My own time? Okay, water issue. These are triggers to water issue. Total dissolved solids, percent rejection, delta pressure, and hardness. Okay, total dissolved solid is what you read as the quality of your water. Typically, manufacturers, when they send out their equipment and have an IFU, has a top limit of 50 parts per million as their alarm point. Most facilities drop that down so that they set their alarm point at 25 parts per million, meaning that obviously 25 parts per million is self-explanatory. So if you're looking at your system and those people that are monitoring it sees an upward trend, it needs to be reported. It cannot be reported when it's alarming. And the reason why you monitor for trend is that you take action before it actually becomes a problem. And that's the same thing with doing cultures, and I'll cover that later on. So TDS, that. Also too, percent rejection. Percent rejection needs to be trended, but percent rejection is the proportion between incoming water and the product water. So you take that relationship and that's your percent rejection. Some parts of the country's water is so good that the incoming water is pure enough so that it doesn't give you a 99 cents per percent rejection in relation to your product water. So if you're in those kind of facilities, you don't have to do anything. You just have to explain, my incoming water is good, that's why my rejection rate is so low. Yeah. And then delta pressure. In our industry, we use a lot of filters in the water treatment system. We use pre-filters, we use post-filters, we use ultra-filters, we use carbon tanks, softeners. Those are filters. When the delta pressure change of 15 psi is noted in those readings, it's telling you that something is displacing its ability to flow through the system. It could be organic matter on your carbon, on your media filters, or in your RO membrane, not RO membrane, but ultrafilters. So 15 delta pressure is what you're looking for, and it requires action. And the reason why you do have to do action in these trending is why? You don't want to get to the point where the facilities, all machines says, no water, alarm. Yeah. So those, and then hardness. Hardness is to protect the RO membrane rather than the patient. So this actually allows us some liberty in actually doing an action. You can actually run hard water through your RO membrane effectively without harming patients. Okay. And then obviously the symptoms. That could be a trigger that you're having water issues. How many of you here know what station is on your water line? What station is the first in line? A few of you? Why do you need to know that? They're getting fed the same water. Is your reaction going to be a domino effect? Yeah, it will be. Yeah. So if you have 5 patients at the farthest point of the RO system having similar symptoms, is it water? There are a lot of other things that we use commonly with each treatment, with each patient. So if it's the farthest point, I would not suspect the water. I would suspect something else that's commonly used for each patient, i.e., yeah. So yeah, water's going to be a domino effect. It's logical. Okay. So in that scenario, symptoms, know where your first station is. And believe it or not, CMS actually looks for that. During your survey, they look for, do you have a diagram of your flow system? Okay. This water issue. 33 patients admitted to the hospital in a 14-day period for anemia, with at least one patient reportedly diagnosed with hemolytic anemia and myocardial infarctions. The test strip used to detect total chlorine were found to be non-reactive to chlorine. So what we're looking for is that concentration, obviously, of anything greater than 0.1 part per million, or, anything that greater than 0.1 part per million is what we're looking for. In that scenario, the strips were found not to be reactive, and CMS actually went out into the field to ensure that every facility was performing what on their strips? Quality control. And the quality control is now part of their survey mechanism. Go, show me your quality control for the strips. So facilities weren't doing it. They were taking it for granted. They opened up the bottle, it's good. But it was not. And so that event happened. Okay. And hemolysis due to chloramines. Wrong test got used for free chlorine tests. And know that in testing for chloramine, is there a test for chloramine? Is there a strip that measures chloramine in our industry? No, there is not. There is no test for chloramine. What there is a test for is total and free. Free chlorine, again, is chlorine that has not been subjected to interactions with any organics. Okay. Total chlorine is after the free chlorine has actually done its job. Free chlorine will react with contaminants to produce combined chlorine. It's called organic chloramine. So your total chlorine is both combined chlorine and free chlorine. What you're supposed to do in the testing is a two-step method. You measure for total chlorine, you measure for free chlorine. You subtract the two, and the assumption is that the remainder is what an assumed concentration of chloramine is. And that's what is the standard way before technology actually gave us a better method. Technology now, and CMS actually accepts this rationale, is that if you measure for total chlorine and measure it to the sensitivity of less than or equal to 0.1, if it's less than 0 to 0.1, you don't have to make the determination what causes that concentration. Obviously, if the concentration is greater than 0.1, you need to investigate what is truly causing your greater than 0.1. Yeah. Get that? So you only have to do total chlorine. You don't have to do the two-test methodology with the DP3 method, the powder form. You can just use the test strip. And the beauty of it is, and again, this is not one of those endorsements, is that some companies out there are literally doing your quality control tests before they ship it out. Meaning that every lot number that they send out has a validation quality control that, yes, this was tested. You take that sheet, put it in your notebook, and that's your CMS surveyor's qualification that you did it. So there is a company out there. Yeah. I think I'm allowed to say that without saying the company's name, right? Okay. So everyone has said that total chlorine? So see how I did that? I blocked it out. So in the total chlorine test strips, it is very procedurally sensitive, meaning that when it says immerse vigorously for 10 seconds, do it for 10 seconds, and then wait 30 seconds. Wait 30 seconds before you do your reading. It is very time sensitive and immersion sensitive. If you are to do this test, and surveyors are actually watching you do this test, and there is nothing in the room that indicates a second-hand timer, guess what? You're cited. Because you are no longer following strict manufacturer's recommendations and instructions in how to perform that test. Yeah, so again, these test strips are very accurate and sensitive to less than 0.1. And they actually have one that if you're trying to determine how much less than 0.1 or how close to 0.1 you have, they actually have secondary tests that will give you that value. Okay, another $10 Starbucks. Who said that? You got it. He's getting all the Starbucks, guys. Okay, this is what 100 patients exposed to greater than 0.1 parts per million chloramines. 41 patients required blood transfusion. RO system demand increased, and their GAC was not upgraded. And obviously, in this facility, the testing of every 4 hours was somewhat ignored, and so the result was they did have a breakthrough of the carbon, resulting in hemolysis to the patients with a reduction of their hemoglobin. And 41 patients required the blood transfusion. So if your facility is expanding and expanding the demand of water, make sure that the design actually includes the calculation for your carbon size. Carbon size is very critical. Okay. Bottled water alert versus do not use water alert. Notice. Do you know the difference between the two? Bottled water means that there's some kind of organic bacterial contaminant that if you boil the water, it's okay to drink. But do not use water alert. They don't know what the contaminant is. It would be a chemical that can actually not be removed by disinfection. So that's the case. So what happens if we receive a boiled water alert in your facility? What do? You stop dialysis? No, because the RO membrane of the pretreatment is more than adequate to actually purify your water to AMI level water, product water. But in a do not use water alarm, a contaminant that could harm our patient may not be removed by the RO membrane because we don't know what it is, and it can get to our patient. So in the do not use water notice, you stop dialysis. And this is the AMI standards as it exists now. Oh, I'm sorry. This is 23500. That's what it says. It's red. And today's current CMS reference is RD52 2004. It was published in 2004, and that's what the government is still using as its reference for our quality, bacteriological quality. And if you notice, there's a difference between water and dialysate. Excuse me, there's a value for water and dialysate. Look at the top graph. It says 50 is your action level, less than 200 is your allowable. 2 endotoxin units with 1 endotoxin unit as your action level. Same thing for RD52 for dialysate. The current standard, current publication of 23500-1 is actually this. And Joint Commission uses those values, and third-party surveyors are using those reference as their values. So if you're using a third party to do your certification or recertification, you've got to change your policies and procedures to reflect that that's what you're following. If you note, there is a difference in the maximum concentration of 200 to 100. Action level is still the same, but look at the endotoxins. 0.25 for water, 0.5 for dialysate. action level 1.25, and 1.25 is still the same. So that is the new standards. Now, the question is there a regulation or an AMI recommendation of what to do when it's beyond the maximum allowable? No, there isn't. There is not. There's nothing that says in the books what you do when it exceeds the AMI allowable level. Bear in mind that prior to 2004, 2008 CMS references, our value for bacteria was, guess how much? 2,000. And there was no endotoxin requirements. In fact, the only time endotoxin was required is if you were doing reuse of dialyzers. And that was the only time. Prior to that, these didn't exist. Did we effectively and safely dialyze our patients? Yeah, we did. Yeah, we did. And the reason is this. If you look at this filtration spectrum, if you look at bacteria, viruses, endotoxins, and if you look at the spectrum of filtration of what filters what, ultrafiltration is here, reverse osmosis is here. Everything to the right of that, to our right, is blocked by those filters. So ultrafilter, guess what an ultrafilter is? A dialyzer. A dialyzer is an ultrafilter. And in most facilities, as an option, guess what they give you? A second one. So if my bacteria, my virus, and endotoxins cannot cross an ultrafilter membrane, and my dialysate and water says that I'm at 300, see that statement? The final decision of whether to discontinue dialysis rests with the medical director of the facility. So if you as a medical director knows that 300 is not going to get to my patient, and he has a potassium of 10, what are you going to do? Stop dialysis? No. No. I would continue dialysis, knowing that my membranes are protecting my patient from dialysate contaminant. 5 minutes? Oh my gosh. Thank you. I had a great game afterwards. Oh my goodness. Anyway, okay. So there is no such thing. It's a medical director's assessment as what to do. Yeah. And I'm almost at potential ultrapure dialysate. That secondary filter in the back of the machine, an option, and the other machines have the option too, is to actually deliver what we can now deliver as an ultrapure quality, which is the 0.1, 0.3 levels of contaminant. And what it does is it's less inflammatory stimulus, less morbidity associated with inflammation, reduced incidence of beta-2 and so forth and so on. It's in the slide so you can read it afterwards because I'm going to go fast. It's located, in different parts of the components. And what's wrong with this picture? That's both the water line feed and the drain line. So if caregivers, please tell them, separate the two. And then look at this. What does that say? What's wrong with the machine? We hate it when clinician says it's broken. What are we supposed to do with that? So we have these so that there's lines that you can fill in to say what it is. Okay? And then obviously this picture is self-explanatory. That's actually a water line, a feed line to the machine. And then the last one is this. This is the reason why we lock our water room. Hospital technician wanted to kill as many patients as possible by pouring bleach into the kidney dialysis machine tank because he was being fired. And the only reason that they discovered this was in the policy of that unit. Their policy was at the beginning of each day, you test your water. And that was the only reason it didn't get to the patients. That amount of chlorine that could harm our patients isn't significantly low that it will not change your conductivity in your machine. So the patients would have been subjected to direct inoculation through the dialyzer of that agent. So lock your water room. And then this is the last picture, is metaphorically speaking, because 92%, 94% of our dialysate is water, it's the largest syringe that we use. And questions? There, I finished. But the other slides is actually fun. It was this, who wants to be a millionaire? Do we have time for a few? Here, I'll show you, okay. So, I'm sorry, what's your name, sir? Your Dave? Dave? Okay, you. Okay, no, there you go. Why is the most common proportion you use currently? See, you can use 50-50, call a friend, or the audience participation.
It's 45.
Yep. What? 45? Yep. Come on. The aiming action level 1, yeah. Well, actually, we're using RD52. So do RD52. It's not 100 though. You're not using the audience participation of 50-50. Now, I had more Starbucks card to give to the participant of this presentation.
94.
94, correct. Yeah. This one's a hard one. Ooh, someone was listening. I've never had anyone go to the very end to collect. I was going to get $40 Starbucks. Now I'm going to have to spend all that money on that Starbucks card on myself. Okay. Okay, this one, I don't know if you're paying attention. I can give you a 50-50, and it's not...
35.
Yeah, 35X. Yeah. Oh, you know that one? It's not A, it's not D, so you have 50-50 chance of 1, 2. C. Yeah. Okay, thank you. And this one is the last one, actually. Yeah. Oh, never mind. Thank you. Any questions? Let me know.